Ready to start up? Okay, we got our first panel on this stage, first panel of the day. This panel is, it's all the rage, direct-to-consumer telehealth. Is it here to stay? And this is going to be a really great panel and has a really great moderator who I've heard for years, and so have you if you lived in the Boston area, Jane Clayson, who is a journalist. And she has a very long history in broadcast, and I'm not going to read her whole extensive biography, but I will tell you that she did like continuous round-the-clock reporting on TV on 9/11. Around 9/11. And she did a lot of amazing things. So she was on network news for a long time, but she's been on radio for a while now on WBUR. And if you're in Boston, you've heard the name Jane Clayson. You know, she also stands in when Tom Ashbrook is not doing On Point. So I hear the name all the time. I hear her voice all the time. And we're all going to get to meet her face to face. So she's going to head this panel. So Jane, come on in. All right.
Thank you. Thank you.
All right.
Good morning. It's nice to be with you all here today. So we have quite a distinguished panel for our discussion today. I invite you to look at their complete bios on the app associated with this conference. But let me first start with introducing Katherine Ryder. She's the founder and CEO of Maven, the first digital clinic for women. Maven is a telehealth platform that empowers women to get access to better health information and services. Katherine is a graduate of the University of Michigan and the London School of Economics. Dr. Roy Schoenberg, on the far right, is co-founder and CEO at American Well, where he introduced the patented technology that now powers the nation's largest telehealth network. Roy holds an MD from Hebrew University and a Master's of Public Health from Harvard. And Dr. David Wong is Clinical Associate Professor at Stanford and CEO and co-founder of DirectDerm. DirectDerm is an innovative company that connects patients and physicians to dermatologists through a secure web and mobile platform to provide consultations, diagnoses, and treatment. David holds an MD from the University of Washington Medical School and a PhD in molecular genetics from the University of Washington and the Fred Hutchinson Cancer Research Center. So just for your information, we will open up the floor to questions for the panel after our discussion here. So if anything piques your interest, you're welcome to ask questions, and we'll save time for that at the end. So I actually wanted to start this discussion today with a poll of you in the audience. I know we have quite a diverse group here. I'm curious, by a show of hands, if you could raise them high, how many of you have participated in telemedicine? How many of you have engaged in telehealth services? Okay, terrific. Maybe I'll start with you, Dr. Schoenberg. Give us a working definition of telemedicine and give us a sense of how many Americans are actually using it today.
So the first one is easier done than the second one, but first of all, thank you for having us here. I think the definition of telemedicine has actually changed. I think historically, and there's probably a lot of people in the audience here who are very familiar with what used to be telemedicine, which was with big fanfare connecting one medical center with another medical center, usually rural and metropolitan medical centers, using a lot of technology, equipment, and people. Since then, the evolution of telemedicine has been primarily affected by the arrival of consumers or patients into the mix, where it's no longer physician to physician or care team to care team, but rather actually delivering healthcare into our environment, into the patient's home or workplace. And long story short, and I'll just try to be brief about it, I think the current more immersive definition of telemedicine is essentially a platform for electronic healthcare delivery. And what that means is that it's no longer defining who the people who are interacting are, but essentially saying what are the infrastructures and technology that allow us to deliver healthcare over technology rather than in person. It's used by patients acquiring services from physicians, it's used by physicians to follow up with their own patients, and it's used extensively between different healthcare professionals to coordinate care around patients. So much, much bigger definition of telehealth. In terms of how many Americans are getting telehealth, you know, Jonathan Linkes from the ATA talks about somewhere around between 1.5 and 2 million transactions. a year. I think that's on the consumer side. But we don't have a lot of data. A lot of people don't publish the numbers. I think that's one of the issues of this industry.
So we did an hour on telemedicine on NPR on Point, and I think it's fair to say from what the listeners were calling in from around the country, they were a bit skeptical of telemedicine. I heard things like, can sending a selfie of my sore throat really provide a definitive diagnosis of strep? Don't you need lab work and physical exams for a proper diagnosis? And a big question many people had was, am I going to trade quality of care for convenience? So Dr. Wong, I'm curious, aren't there a rather narrow list of health problems that are best suited for telemedicine?
Well, so telehealth, as Ro was saying, it's allowing technology to enable services in a way that we weren't able to provide before. And so telehealth is a tool, a great tool that we can use to improve the quality of care and do it more cost efficiently. But the quality inherently is dependent on how that tool is used. So number one, it's inherently dependent on the quality of the providers behind it. So if it's a telehealth service in which you're providing direct to consumer, the quality of service obviously depends a lot on the providers providing the service. So just like when you go in person to get service, the quality depends essentially on the experience, the skills, the training of the dermatologist, for example, in the field of dermatology, or other physician that's providing the care. The other thing is that, certain services, when we think about it, I think we have to think about telehealth is not think about it as providing care by telehealth in isolation. We have to think about how telehealth looks as health in the general. I think envision where it's going to be when it's just part of standard of care. And so it needs to be connected and integrated with our entire care delivery system. It has to be part of an entire care model. So, for example, in DirectDerm, we really think about really reimagining and reinventing the way we deliver the care model. It's not just using telehealth. Telehealth is a component that allows us to do that more efficiently and provide more cost-efficient care. So, for example, some things that patients come in to see us to use DirectDerm, for example, are very straightforward. Say they have a condition of mild eczema, for example, which is a common rash. We can manage that virtually very easily. But then patients come in with rashes, for example, that we suspect, they might have an autoimmune condition. In that case, you have to have workflows and services in a full care model where you can order labs, do further workup, bring them in person, refer them to other specialists like rheumatologists in that case. So I think we have to think about it as a tool in which we can provide care. In some cases, we can provide it truly with just virtual care alone, but in many cases, it's basically connecting to our healthcare system for other services that require, for example, more workup.
So Kate Ryder, jump in here. Dr. Wong talks about delivering care. Tell us about your business model and how you deliver care specifically for women's health.
Yeah, so just to agree your point, I think it's the ATA that says about 70% of the time you don't actually need to go see a doctor in person. So, you talk to a lot of moms with kids who are missing work to go to the pediatrician to see this rash. So, telemedicine's really helpful and convenient in those situations. With us, we use so many different types of providers. So we use, OBGYNs and pediatricians, but we also work with lactation consultants and women's health physical therapists and mental health providers where telemedicine is, a really easy use for a lot of these issues. So a woman needing help breastfeeding at 10 p.m. on a Sunday night, that doesn't require an in-person visit. A lot of mental health visits as well don't. And so, we're really seeing, I think, the value in delivering care this way and just providing greater access to women through these services. And, the other thing I would mention is that because we work with so many different types of providers, we have a coordinated care model, which is really hard to find in the system today. So, for example, if a woman just has a baby, then she would, on Maven, get to work with a lactation consultant, a mental health provider, a pediatric nurse practitioner, and a women's health physical therapist who are all sharing notes and kind of her care team, so to speak, to really provide that coordination during a time when you're working with a lot of different care providers.
But what about data distribution, Kate? I mean, and how do you deal with patient records? I mean, sometimes they are sharing notes, but sometimes they're not, right? So the patient records that may be in different hospitals, different doctors, how do you get those all together?
Oh, so we're definitely, it's our system. So to try to tackle the patient records and bring them all in your own system across the U.S. is, I think, impossible, and no one's done it. But it's with our care team. So, you know, for instance, if a woman is experiencing postpartum depression and she also is having trouble breastfeeding, you know, those providers need to be talking because actually one is feeding into the other. So when I talk about coordinated care, that's what it is.
Dr. Schoenberg, telehealth may be a new option for patients, and a lot of people may be taking advantage of it. But as a business model, is it worth investing in?
Well, I think it depends who you ask. And, you know, we talked about a couple of different models of telehealth, and I think the thing is that people try to mix together the ROI and say that must be such a disruptive thing, it's going to be like Amazon tomorrow, but it keeps not happening, so people are concerned. I think you need to have clarity about where you're going to get the ROI. And the telehealth that allows patients to quickly get in front of physicians or anybody that can prescribe a Z-Pak is primarily delivering value to the health insurers who are trying to make patients not get to emergency rooms and urgent care centers because they are much more expensive than telehealth. And those payers who have deployed telehealth in that way not only have generated revenue but actually documented return on investment in hundreds of dollars per transaction. And that's squarely there and great. Then we see the other type of telehealth, which is physicians using telehealth to follow up with their own patients. The numbers of telehealth transactions are smaller because you're not, you know, a smaller part of the population of America is sick with chronic conditions and everything else than the general population. But when you think about how you follow up with a cancer patient at home during the 2 years of chemotherapy and what you can intervene on and prevent bad things from happening and what the implications of those things are, the value of every one telehealth transactions is not $39 or $49, but it's in $10,000 of preventing a readmission for one transaction. So the ROI is measured completely differently when you deal with follow-up care, and I think one of the reasons why telehealth is booming in this world is because most hospitals and physicians are gradually taking risk for those patients. So they're buying it. And then lastly, the use of telehealth between physicians means that large health systems that don't have a neurologist in every corner of their buildings or their different campuses can hit a button and say, I need a neurologist, and the system, a little bit like Uber, is going to run around through that network's ecosystem, find an available neurologist and beam them, a little bit like Star Trek, into where that neurologist is necessary, which means you don't have to staff everything everywhere. And that's enormous efficiency in terms of just, you know, spending. So the bottom line is that there is ROI, but if you don't take the time to think about where am I deploying it and for what purpose, like everything else that's got nothing to do with telehealth, you'll probably miss out.
Dr. Wong, you're shaking your head. Do you want to add to that?
Oh, absolutely. I think Roy's exactly right. It's, you know, I think healthcare is obviously a very complex industry. There's a lot of stakeholders within the industry. So it's very important to show value and ROI to, as Roy was saying, the multiple stakeholders, the patients, the providers, the payers, whether it's employers or health plans. You need to show that ROI across the board in order for this to really really scale, become, you know, standard of care, to be something that, to get to that vision where we consider it just part of health. So absolutely, the key is really making sure our programs are really aligned with all of the stakeholders.
Kate, how have you been able to scale Maven to the degree that it is today?
Yeah, so I mean, talking about ROI, so because we're verticalized in women's health, we're able to kind of zero in on some key KPIs in the industry, or actually key metrics in the industry that are pretty terrible for all of these stakeholders, the payers, the providers, the patient. And so we have a combination business model of a B2C marketplace as well as a B2B maternal health business where we sell into employers and payers for our maternity benefits product. So, and which is this kind of coordinated care model for pregnancy and postpartum, and then also back to work transitions.
So typically doctors have been licensed in the state where they practice. So I'm curious, with these models, are there regulatory issues that are a problem with telehealth?
Yeah, there definitely are. That's certainly one of the barriers that's there. You know, there's a lot of state-to-state regulations on what is allowed and what is not allowed. There's obviously crossing state line issues where, you know, providing care across state lines. You know, I think the tailwinds are picking up, though, to help telehealth. I think there's a lot of things going on. For example, more states are adopting parity laws, supporting telehealth as an equivalent way of providing service as in-service care. There's a lot of parity laws on payment of reimbursement at similar levels as in-person care. So a lot of tailwinds there, but there are still a lot of barriers due to state regulations that we need to still work with.
Right, oh, go ahead, Kate.
I was just going to say having a good lawyer is a competitive advantage in this industry.
You know, I'd say this. I think every other industry that's not healthcare seem to have realized that we need to think about how resources are being distributed differently. If you think about the whole retail industry, Amazon changed our concept of where the goods are. They're no longer in the shops on Newbury Street. They are in giant electronic, you know, warehouses that machine their way to get the goods to you the way that you want it. That's where the inventory is. Uber, on the other hand, changed the way we look at the inventory of cars. They're running around us, and they found a way to tap into them and load balance them and make them available to us at the click of a button. Telehealth is the opportunity to do the same for healthcare. It's a revisiting the notion that inventory of physicians that you need to see are the people that are in the building next to you. And even though we're very slow to understand that, you know, because this has become the reality through technology of every other industry, even healthcare will not be able to resist that. And we're making progress in lifting those barriers of arbitrary barriers of state lines with probably the arrival of the licensure compact in January, where they're going to start distributing multi-state or facilitating the distribution of multi-state licenses. But this tidal wave is going to hit us within the next 12 months.
But the inventory of doctors does include, in some companies, overseas doctors in interacting, right, with doctors that are overseas. That seems well beyond U.S. regulation, doesn't it?
Yeah, I think we need to pick our wars. I don't think anybody. There are great physicians overseas. There are many physicians overseas that have trained in the U.S. and actually carry a U.S. license. But I think you want to be cognizant to people's trust. And I think telehealth has to be very, very careful in the way that it makes services available, not to breach too much beyond what people feel comfortable with. I want to see, frankly, I'm already uncomfortable about the notion that a telehealth system brokers engagement with a physician I don't know. I think, if anything, telehealth has to actually learn to respect the brands that patients respect. So if I get my physician network from, and I'm not promoting one or another, from Blue Cross Blue Shield, telehealth should facilitate that too. And if I want to be seen by a Mass General physician or a Cleveland Clinic or a Mayo or anybody else, that should be available to me through telehealth, not physicians who are broadcasted from Sri Lanka.
Yeah.
I was going to say, just on this inventory and supply issue, so we work with a lot of nurse practitioners too, so that's another battleground in terms of kind of, you know, regulation in healthcare. So there's 22 states where nurses have scope of practice, and you know, Massachusetts is not one of them. It should be, anyone in this audience. And so anyway, so that's also a way to kind of bring supply to underserved populations while not using overseas physicians because they aren't credentialed or trained here.
David?
Yeah, I think quality, you know, I think it's very important that we're very transparent about the services who's providing those services through telehealth, and that patients have choice, like Roy said, about who is providing their care, just like you do in person. So I think that's absolutely critical. Yes, we do have a shortage of providers in the US, but telehealth allows us to be much more clinically efficient. So, you know, with dermatology, we can be a lot more efficient in the ability for our dermatologists to provide more care to more individuals more efficiently. So, you know, using that, I think at DirectDerm, for example, we're very transparent about our network of dermatologists, who's providing their care, what their credentials are, all board-certified dermatologists. I think all of us, that's critical because we need to gain the trust of our patients of all the stakeholders about who's providing the care and the quality of care. If we, for example, patients have bad outcomes and don't experience the power of telehealth, they're not going to come back to use it.
It makes me wonder, though, who should provide these telehealth services? Should it be the insurance companies? Should it be the hospitals? Should we have new providers altogether? I mean, won't telehealth benefit largely those who profit from it?
I have a short answer to that question. I think whoever can drive patient engagement and gain the trust of the consumer. So I think that's what we're talking about today is healthcare consumerism. And I don't think anyone in the healthcare system has done a very good job of that.
You know, I think Amazon has been very successful by the fact that you can buy a Samsung TV on Amazon, not an Amazon TV on Amazon. We need to respect the fact that, you know, there are healthcare organizations that have created trust over hundreds of years, literally. I mean, the Mayo Clinic is an example, and you know, Partners Healthcare and Mass General. Telehealth will only survive if it facilitates and creates easier way for patients to interact with those brands who have been, you know, built over the years because of credibility and proficiency. We're not going to completely reinvent healthcare and create another kind of healthcare world that's called telehealth. Telehealth is not a destination. It's a means to an end. So I think, you know, the health insurance companies, if we all have, you know, hopefully some insurance, the way we find physicians is we go and look at their, you know, the provider directory of our health insurance, and that's how we find physicians we want to interact with. But those physicians are actually not Blue Cross Blue Shield of Massachusetts physicians. They belong to Brigham and Women. They belong to, you know, to Beth Israel, whatever it is. That same balance has to continue to exist in healthcare. There are facilitators of healthcare, like you get health insurance from your employer, that's going to continue to exist. Your health insurance company facilitates the networks and makes sure that they're in good quality, and the physicians work in delivery networks that carry credibility. Telehealth has to embrace that rather than to disrupt that.
Is insurance keeping up? Are insurance companies welcoming to this technology?
If you're a health insurance company and you don't offer telehealth by the end of this year, you're going to gradually be marginalized. It's that bad for them. Good. I mean, depending how you look at it, I guess.
Depending on how you see it, yeah.
Yeah, no, I think that health plans are thinking more forward thinking about how critical it is to be able to provide these types of services. They need to provide better networks. I mean, their networks are limited. They understand the gaps in where telehealth can really fill and solve some of their challenges in network access and improving efficiency. So I completely agree. It's still a progress, but I think health plans are slowly starting to accept and offer telehealth.
Okay.
Yeah, though I would say that, so I think health plans, though, are trying to figure out how to drive utilization through their telehealth services because they are pretty low. So, for instance, one health plan that incorporated a few services wrapped everyone under the name of a virtual doctor chat, which is not really going to interest, I think, and entice a patient. So I know from that, you know, utilization when insurers do that is pretty low. So I think it is also, you know, we're all on the same team from a price standpoint, from a care delivery standpoint, from an access standpoint, but I do think it's, you know, respecting the brands in healthcare that drive kind of patient trust.
I would even go a little bit more aggressively, and I would say if you're a health insurance company today and you don't offer health plan, you're telehealth, you're a little bit like corporate entities 15 years ago that didn't put in an email system.
So one of the big issues is reimbursements. Traditionally, doctors get paid for seeing patients in person. Are doctors getting paid the same for virtual visits as they are for in-person visits?
I think it's variable. I think there are parity laws that have been come out of multiple states that are stating that reimbursement should be on par with in-person visits. But I think it's still variable. I think reimbursement is still something that's not standardized across the industry. I think it varies also specialty to specialty and what type of services, what modality you provide it in. So it's still a challenge. But there are tailwinds that are reimbursing on par with in-person visits.
18 months ago, there weren't parity laws. 18 months later, where we are now, there are 30 states that have introduced those laws.
Right.
So if you think about the glacial pace of healthcare typically, this is unbelievable in terms of reimbursement. The problem is not so much the embrace of those laws and the recognition that physicians have to be paid for seeing patients through telehealth. That's there, and that's going to be 50 states before we know it. The issue is that the laws, nobody understands now that there is a law what that means. It's a little bit like, there are laws around jaywalking, but that doesn't mean that people don't cross the street. Every state that has a parity law stipulates why is it that physicians need to get paid, but if you ask 9 out of 10 physicians in that state, how do they get paid for telehealth? They won't know, which is shocking given that you would think they would like to make an income, but 9 out of 10 don't know.
Okay.
Yeah, I mean, just talking about a lot of the misinformation or lack of information in the industry, I just learned something last week that was fascinating, that, so in telemedicine, you can prescribe a lot of medication, which is really useful to patients who need it. And because state by state, there are very different laws over what you can prescribe, nobody has come up with a comprehensive list of state by state drugs that are allowed to be prescribed in telemedicine, which blew my mind because that should be readily accessible information for any telehealth company, for any health plan, for any provider. So I do think that a lot of this needs to be simplified on the back end.
So there was a recent study, Dr. Wong, in the Journal of the American Medical Association that found quite a lot of problems with misdiagnosis of skin issues in telehealth. Will you talk about that a little bit? What you thought of that study? Was it valid?
Sure. Yeah, it was. It was a small, limited study. It lacked controls to look at quality of telehealth compared to in-person care. But it did bring up some important issues that I think we've talked a little bit about already. Is number one is the quality, which includes accuracy of diagnosis, proper treatment plans, good patient outcomes. Really depends on who's providing that care. So there are services out there that are using providers abroad or providers who aren't board certified or who are not even in that case for dermatology issues, not even dermatologists. And so quality inherently is going to be compromised when there's no transparency and the quality of the provider isn't what the patient expects. And it's something we as an industry have to watch because that kind of soils the industry, because telehealth, when provided and used correctly, is a great tool and will become standard of care. The other issue, again, is really making sure that we're all following. I think it brings up good points of best practices, and that just like we do in in-person care, providing best practices in how we provide that care. Again, it's about care coordination and integration with the health system. Again, it's not looking at that encounter as one siloed encounter. It's something just like, patients can follow up through telehealth. People can go to be triaged and go to in-person care if they need to. For example, a growth that we're worried about might be melanoma. It allows getting those patients in for not only that immediate engagement, so telehealth allowed the patient to come in, not wait, be able to have access to have that spot assessed quickly by a board-certified dermatologist, but then getting them in for that biopsy immediately within the week, for example, to get that biopsy done and then get that full service of care. So all those things have to be part of the service, and again, it's about providing that care model that ultimately provides patient outcomes. It's not just using the tool of telehealth.
It just reminds me, first of all, there's a lot of issues with delivering accurate telehealth, and I think we're going to learn as we go how we can mitigate many of them. But that reminds me of actually one of the godfathers of telehealth, or the fathers of telehealth, Jay Sanders, who may be here, said when we're looking at the means of delivering healthcare, until we actually get into it, we don't really understand the things that create misdiagnosis. Like, for example, today we use echocardiograms and everything else, but historically physicians used to diagnose heart conditions with a stethoscope. But nobody came up with the question, are we doing hearing tests for cardiologists as a required certification? The stethoscopes are great, but that's an issue. We will learn, we will understand eventually what are the things that create most of the issues with telehealth diagnosis and treatment, and we're going to implement tools. The same way as, when we started doing online retail, credit card transactions weren't, necessarily safe, and now we have better ways of doing it. FedEx didn't work the way that it does today. We are going to improve, but that's, going back to the email analogy. If we're going to sanction telehealth because there are sometimes misdiagnoses over it, that's the equivalent of saying, because there is the fear of spam, why don't we not implement email? And we got to get over this.
Yeah, I totally agree. Two other points. One is that, the time at which you're seeing your provider in person is also becoming so short. And, as a patient, you might be spending a lot of time on Google ahead of time. So you ask your provider a lot of questions, then you only have 3 minutes with them. There's a lot of misdiagnoses in person as well. And then, so I definitely think that should be.
But how do you manage around those limitations at Maven for women's health issues? How do you actively manage around that?
For misdiagnosis? Well, first of all, we have almost 1,000 providers in our network, and they're very cautious. And if something needs to be seen in person, they say, go in person. So there is a limitation to what you can do over telehealth. I mean, I think every healthcare provider understands that. But if, for instance, we're screening for postpartum depression, and that's an example where we're unsure, but also the entire healthcare system is unsure whether some women have postpartum depression or not. And so I think it's doing the best you can, but again, it's the same dynamics in person. And I will say, premiums for medical malpractice in telemedicine are low because there aren't a lot of cases of med mal, if any, that very few in telemedicine, whereas a lot of it is actually more in person.
So Dr. Wong was telling me earlier about a nonprofit, or some nonprofits that you're working with, which I thought was really interesting. Tell us what you're doing and accessing certain populations with telehealth.
Sure. Yeah. So DirectDerm has been working with the California Health Care Foundation and Kresge Foundation to help bring innovations to underserved communities. So we have to talk about, the improvement in the quality of care that telehealth provides. It's not just something that's more convenient. It's about the quality of care that happens, especially most markedly in these underserved communities. So in underserved communities, patients are waiting 6 months, a year to see a dermatologist, which is unfathomable in the US. You would think, with our healthcare system, our great physicians, our health, all of this, that it's unfathomable that a large percentage of our population are waiting 6 months to a year to see a dermatologist. And this is, a problem with a lot of different specialties and a lot of physicians just having basic access. And this is something that actually affects outcomes. When you're talking about people who have a changing mole on their skin, we're talking about something that that turns out to be melanoma. We have a lot of undetected melanomas that we catch at late stage, which ends up, melanoma is a type of skin cancer that's highly metastatic, has very bad outcomes if you don't catch it early. So the power of quality of, care that we can provide, it's really our social responsibility to use telehealth, because by not using it, we're really doing a disservice to these communities. And so we've been able to, there was actually a JAMA dermatology study that was done by Dr. Malhotra from Harvard and RAND Corporation that looked at work that we did with a managed care plan in California for an underserved community. And we found that we doubled the amount of access that patients had for dermatologists, and that was still under the amount of access that commercial patients, commercial insurance, really good insurance patients had. And 75% of all the new enrollees through the ACA were receiving care through DirectDerm. So, with the challenges of providing these access gaps, the power of telehealth, it's really our social responsibility to really use this and integrate it into our healthcare delivery system.
How do you see the possibilities for serving, underserved populations and communities?
We're already doing it with the Maven. We have a thing called the Maven Foundation. So every time you book an appointment on Maven, $1 gets donated to a woman in need. And what we do is we started with breastfeeding, which is a great application of telehealth. We partnered with 5 nonprofits, and we are distributing lactation consultant appointments over our network to postpartum women in lower income communities. So that I think is a great example.
Dr. Schoenberg?
Well, 49 states have already introduced exemptions into their Medicaid rules to allow the use of telehealth. I can tell you with no pride that the one state that didn't is the state of Massachusetts. It's just the way it is. But there's no question that, especially when you have a vulnerable population, the arrival of healthcare resources to them is challenged in a lot of different ways. If you think about what can happen in a federally qualified health center where you deploy a telehealth kiosk and within a click of a button, literally most of the relevant specialties are going to on-demand show up and give care to patients. You are equalizing, democratizing access to healthcare to a lot of people that really need it. And it's not philanthropy. I mean, if you don't care for those people, they will end up in an emergency room with a much worse situation for everybody involved. So the opportunity for telehealth to become one of the most powerful instruments of really equalizing healthcare access and quality of healthcare delivery and follow-up is mind-boggling. And I think we're completely missing out on an opportunity to make that change happen earlier rather than later.
Do you expect more competition in healthcare with telehealth? A company based in Boston maybe trying to recruit patients in California, for example.
Yeah, the short answer is absolutely yes. And it's actually more fast and furious than I think anybody thinks. We were, where I come from, we actually were in a funny situation, a funny opportunity where we have a lot of payers as well as health systems, delivering telehealth over our system. And earlier this summer, we introduced something that allows them to begin to create business relationships. So that, for example, Cleveland Clinic physicians are now available over Anthem's Live Health Online. Both systems are using the same technology. The result of that, and especially if you couple that with the licensure compact, means that brands in 2017 can begin to completely rethink where they're available. It means that if you're a relatively small hospital in Connecticut and you have a great headache program or a headache migraine program, you can make it available nationally. It also means that, so you can compete where everybody else is, but it also means that the other guy, like Mayo Clinic, can open up shop in Connecticut. And the only thing that means is it's a good, healthy competition, but it means that people really, and this is the last minute, people have to rethink about what is their wingspan and where they aim to do business.
Yeah, I mean, I think that the future of all of this is branded, it's verticalized, it's being an expert in something and then branding it and trying to, build a national brand and gain that trust of the patient population and attract as many patients. So I think that the next 5-10 years you'll see a lot of that, and hopefully that means better healthcare for patients.
Dr. Wong?
Yeah, no, I think competition is good for our industry and, allows patients more selection and access to basically care from whatever brand, whatever institution they want to access it. So it's a great thing for our industry.
It makes me wonder, will easier access to doctors mean more demand for doctors?
So I think this was, when we started doing this about 10 years ago, this was probably the #1 topic of discussion when we talk to payers. They said, you're going to make it so easy for people to do this. They only pay a small copay. There's nothing good on television. Every night they're going to go in and talk to doctors all night, which is great because they actually ask you how you're doing. They really want to try and help, compassionate people and everything else. And that was the concern. And a lot of the systems that evolved over the years have actually implemented a lot of capabilities to monitor for the frequent flyers and monitor for the people who are abusing it, the pill poppers, all of that kind of stuff. And the long story short, and there's now very, very detailed studies that were done both by Anthem with its 36 million patients as well as by United Optum on urgent care telehealth that have both proven that that's just not the case. For some peculiar reason, patients actually do have appreciation for physician time. the structure of either the copay that continues to work or something else have resulted in the fact that telehealth actually ends up saving money rather than creating overutilization. And there are numbers around that are very, very clear.
How do you see it at DirectDerm, Dr. Wong?
Yeah, no, we see that. I mean, I think the things that we see really are people with relevant problems. I mean, we don't find people just, it's not something even though it's accessible, that someone just wants to consult a doctor for no reason. So there are real reasons, and as providers, we want to provide care that's meaningful, so forth. I mean, when we looked at, for example, providing care within the underserved communities, these were real problems. And to be honest, we saw a lot of severe problems, more than we see in normal practices, because of the lack of access for so many, for years, that these patients didn't have access. But even then, utilization was still well within what we sort of see as the norms of utilization with in-person care. So something that we just don't see, but something obviously we continue to monitor.
Yeah, and I think the other thing to mention is this is where you can do really cool things with the product. This is a technology at the end of the day, so there are different modalities of ways to communicate with providers, whether it's messaging, whether it's video appointments, whether it's calls, but then also connecting you with other patient communities to get the support and care. So it doesn't always have to, I think telehealth can provide that access, but ultimately, if you build a product in an interesting way, then really it's from a business model perspective, you want to triage it appropriately. So I think a lot of the products are all moving in that direction.
So this is the part where you say that it makes overutilization. We come in and say, wrong.
So as the daughter of a vascular surgeon, I have to ask you, what does this do to the doctor-patient relationship when consultations are through a screen, when you may get a different doctor every time you log on? It's a concern.
So I would say we definitely try not to make it a different doctor every time you log on with care teams and whatnot, with all the ways that you can reach your Maven practitioner. So I think that the commoditization of the industry and just transactional, I need a prescription for a sinus infection, give me what I need, I don't even know your name. There's some value in that, right? Because you're getting somebody a very basic prescription, but for real care, I actually think this can enhance the patient-provider relationship in profound ways, because you can follow up with them, you can message them when you need to, and just get access in ways that just seeing your primary care physician or your OB might not give you that satisfaction, give you that care, because we keep saying doctors, but there are a lot of other healthcare providers in the system that are delivering great care.
Go ahead.
Okay. I think the interaction and the relationship's just going to be different. I mean, I think, there are now different modalities in which you can communicate with your providers. It's not, you have to take time off from work, drive over, parks in their waiting room, and sit with them for often 2 minutes, and then you're out. That's the extent of your interaction. Actually, you have more opportunity to engage with your provider, more opportunity for a provider to more efficiently engage with the patient to provide better care. And so it's not a replacement, it's another piece of, again, the care model and how patients can experience. So it is different. I think providers are adjusting to how they interact with patients. But in the end, I think, again, it's a good thing. I think in the end, better outcomes, more efficiency for the doctors to provide better care for their patients.
Roy?
Yeah, I think this topic was kind of dominating the discussion around telehealth for a good number of years, but I think for the most part it has sailed away. Because I think people understand that there are different relationships. It's not one thing. And sometimes relationships are necessary to be able to communicate or that generates diagnostic proficiency, and sometimes relationships are about follow-up and supporting patients, and sometimes it's because there is specialty knowledge that is necessary to get to a physician, Sloan Kettering, for a specific kind of cancer. The notion that we're going to dominate or we're going to moderate how relationships are being built just because we control the channel of communication makes absolutely no sense, and I think for the most part people have moved on beyond the notion that telehealth is bad for relationships. It isn't.
Yeah, and I just what's going on with the relationship offline, right? So it's not like that's a great system.
I want to open it up to questions if there are any. Please go to a microphone. And while you're doing that, I'll ask, is there a gender disparity in telehealth? Are women disproportionately, bigger consumers, if you will, of telehealth?
Yeah, I mean, I think the stats are about 75% of the telehealth market are women. I mean, we're obviously 98% women. We do have some male patients. But yeah, I mean, I think women drive 80% of healthcare decisions in the U.S. Women are the primary healthcare consumer. They outspend men. They're the chief medical officers of their homes. And so in building a lot of these telehealth services, if it's for kind of primary care, reproductive health, mental health, wellness, you should probably be building with the female patient in mind.
I think on the urgent care part, there is a slight preference for women. It's not dramatic. It used to be more. I think maybe women were more inclined to use an innovative, technology to solve a problem. Right now, with large numbers, it's about 55-45, so not dramatic difference. But when it comes down to telehealth that's being used by physicians to follow up with their own patients, there's literally no difference because the physicians are the ones deciding when to use telehealth. So I think that's actually going to completely normalize.
Yeah, we're seeing the same thing in dermatology. I think it's a slight more female, but it's pretty equal. We're seeing men utilizing it.
Great, thank you. Yes, thank you.
Good morning. As an attorney who's been in the regulatory part of telehealth for a decade, I'm still troubled that Medicare will not reimburse telehealth when the patient is in her home to receive the service. I wonder where the panel members' forecasts are for Congress lifting that barrier sometime soon.
There's over 200 different, and you surely know that, there are over 200 different bills in Congress in this legislative session around embracing telehealth. Maybe one will get through, I don't know. Clearly we're going to have to wait for November to figure out what the mix is in Washington. The one thing that has happened, however, is that Medicare has been very, very, very careful about introducing it. Primarily the issue is that the Congressional Budget Office couldn't score the value of telehealth, which is, again, coming back to email, like imagine the Congressional Budget Office would have to score the value of email. Like, they don't know how to do that. But they're beginning to put it in the different bundles that are coming out. The cardiac bundle now covers it. The hip replacement bundle is covering it. The next generation ACO does cover telehealth. So it's slow, it's agonizing, but it's moving in the right direction. We would love it, we would love for it to happen tomorrow, but we're crazy.
Thank you. Yes?
Yeah, sort of expanding on that. When doctors follow complex or unstable patients, really ideal care involves a lot of modalities of communication with the patient, not just telehealth, but phone calls, secure emails, remote monitoring of physiologic data. And so often each individual transaction may just take a minute or two. But what I know from my experience is that it adds up. It's not paid for. So doctors often don't do what they know very well would be the best care because it falls outside of the reimbursement structure that they have to live with. And what are your thoughts about creating some sort of, playground, safe space for doctors to really try to figure out the best way to take care of high-cost patients where they don't suffer financially for being creative?
I think it exists. I think this is what the ACOs are all about. If you think about it, it's a model where physician groups with certain structures are able to get defined payment for patients, and if they manage them more effectively, then there is an upside, and if they manage them poorly, there's a downside, but it really doesn't discriminate what tools you use to do that. It's not perfect. It's still, there's a lot of question marks, but the transition towards fee for value may actually solve the problem that you raise, and I think you're right on the mark that's an issue.
Yeah, I think I completely agree. It's, I think it's as we move towards value-based care, it's going to be something that that allows providers to really provide best care. There's a lot more interactions, obviously, with more complex patients. There are the simpler patients. And so, I think it will, moving from fee-for-service to value-based care is, ultimately going to reduce some of the barriers and difficulties in providers being able to provide that ideal and intensive care for some of the sickest patients.
Getting the hook from backstage. So if you do have a question, I think the panel members will be off to the side if you'd like to come over and speak with them further. But I'd just like to say thank you to Katherine Ryder, founder and CEO of Maven, and Dr. Roy Schoenberg, CEO of American Well, and Dr. David Wong, CEO and co-founder of DirectDerm. Thank you very much.
Thank you.